Welcome back, ladies and gentlemen, to another fabulous episode of the Healthcare Trailblazers podcast. Very excited to be sitting here today with Dr. Mallick, is the Chief Medical Officer at Medicaid and CHIP. For those of you that don't know, that is the government. that is healthcare for basically probably millions of people, tens of millions. I don't know how many millions. How many millions?
91
millions. She knows exactly how many millions. 91 million people across this fantabulous country that we live in, until age 65 when people go up to Medicare. So we've had people from Medicare on, and I'm excited to be sitting here with Dr. Mallick, who's from Medicaid. So Dr. Mallick, Chief Medical Officer, thank you so much for joining us today.
Thank you for having me. And I will just clarify that Medicaid still actually covers people over the age of 65 as well. Medicaid covers people cradle to grave, actually. Beyond overdose.
Let's jump into it. Where did you grow up, and why, and what got you interested in medicine?
Yeah. So born and raised in Fort Lauderdale, Florida. I'm the child of Indian immigrants. So both my parents were born in India. They had an arranged marriage. They lived in London. My older sister was born in London. And when my mom was 5 months pregnant with me, they moved to Florida. So I'm the only person in my immediate family that was born technically on U.S. soil. And I say the defining moment, in addition to being the child of immigrants, that I think comes with a lot of interesting twists and turns, I'll just say. The defining moment of my childhood was when my dad was diagnosed with stage 3 esophageal cancer. And that was in the fall of 1997. So I was 11. He was 42.
You were 11 years old?
I was 11 years old. My dad was 42.
Okay.
My sister was 13. My mom was 40 or thereabouts, just shy of. And my family didn't have health insurance. I mean, we had health insurance as kids because of the Medicaid program. Like Medicaid and CHIP insure, and your listeners may know this, but insure 42 million births, or 42% of births in this country, and over 40% of children in this country. And so we could get our immunizations and stuff as kids, but my parents didn't have health insurance because they were small business owners, and this was pre-ACA. And so my dad was a UK citizen. He actually flew. It was more cost effective, believe it or not, to fly to London to see an NHS doctor than it was to see an oncologist.
Wow.
Let that sink in. Ultimately, the treatment plan was for chemotherapy. This was, well over 20 years ago. So there weren't the same sort of sophisticated, targeted immunotherapies that are available now. But ultimately, the last few months of his life were weekly chemotherapy that my family had to pay for in cash. So about a 45-minute drive at the University of Miami Cancer Center. For a family that also is raising 2 children and trying to run a small business. So when my dad ultimately passed away, I think a couple huge reflections or learnings for me. The main one being no family should ever have to go through that. How is it possible that in the wealthiest country in America, or the wealthiest country in the world, that's a lived reality for people. And unfortunately, my family is not unique in having gone through an experience like that. And so I was 12 when my dad passed away. My infinite 12-year-old wisdom thought, well, if I were a doctor, I wouldn't be able to fix or change what had happened to my family, but I could at least help make sure that it didn't happen to anybody else's family. So that's how I got interested in medicine or healthcare. And then fast forward, when I was in college, had the tremendous good fortune of taking classes with Don Berwick and David Blumenthal and the late Paul Farmer, and became so struck by this idea of what I lovingly call Doctor Plus, just to say people that are trained as clinicians, as physicians, but do a lot of plus, a lot of other things, and in particular around health systems improvement and health policy with an eye towards social justice and really making our health system more equitable and work better for individuals and families that need it to work better for them. And once I got that bug, it's, 20 years later, I haven't been able to shake it. So that was how I came into medical school. Like I sort of approached medical school knowing that I likely wouldn't be a full-time clinician, that what I really wanted to spend my time on was health policy. And actually fell in love with taking care of patients, and what a privilege it is to sit with people in their most vulnerable moments and be able to help and serve and look in the eyes of people that you're helping and taking care of. And for people to allow you into their lives in those moments, such a privilege. So went to residency because I wasn't ready to give up on clinical medicine. So I'm trained as an internist. And since I finished internal medicine training, have maintained a clinical practice predominantly as a hospitalist, but my day job has always been in health systems or in health policy since then.
Wow. I just want to take a moment to appreciate the contrast. You're an 11-year-old girl whose father unfortunately passes away, and I mean, it was, I don't know if the, like you said, I don't know if the outcome necessarily would have been different, but definitely the process would have been different had you guys had and medical care and the havoc that I'm sure that just to the family, having to travel to the UK, and I mean that's just a crazy origin story. And to contrast that with that 11-year-old girl and now you're not just do more people have Medicaid. You are the chief medical officer at Medicaid. That is a fantastic contrast. I mean,
I've had a lot of wonderful support over the years, and I have a family that supported my education and every twist and turn along the way. But I mean, for me, it's deeply personal. I guess is the point, right? That that albeit from a national level and for 91 million people, but it's 91 million individuals, right?
Right.
Who make up families and communities, and that's who the work is for.
Yeah.
So that access to coverage, health insurance coverage, and access to services are foundational to peace of mind. They're foundational to being able to thrive and live a healthy, productive life at any age. And that's, a core part of why I do what I do.
Yeah. Let's talk about the role of government when it comes to healthcare for a second, because I think that it's very understandable, somebody in your shoes as that 11-year-old girl that's seeing, you're seeing the result of, millions of citizens in, like you said, in the richest country in the world not having healthcare. So I think it's very understandable that perspective, but I feel like it's what probably often happens once somebody crosses over that bridge into being part of the solution, so to speak, is that you get the perspective from the other side and you realize, either it's not so simple or there's other ramifications that, you can't just write blank checks to everybody. At the end of the day, you can't snap your fingers and all health challenges go away. So now that you're in government and you're running Medicaid, in your mind, what is the role of government when it comes to providing healthcare, and at where is that line in your mind between requirement almost of the country to provide healthcare? And obviously you said, your family's coming from the UK, where it's obviously a very different system. And my understanding, my sister lives in London. My understanding is everyone just has healthcare, and that's almost like a right. Versus obviously there's this, in America, where there's kind of two sides of this argument. The other side is, well, if the government completely takes over control over healthcare, now they're controlling what doctors get paid, and now you basically start messing with the free market side of healthcare that obviously Americans love free markets. So if we can talk about that a little bit, in your mind, what is the role of government, and at what point is it overstepping, and where is it helpful and where is it not helpful?
I will give you one woman's opinion. So
absolutely,
I don't need to speak for everyone who works in government at all levels. But my view, we have a moral obligation to take care of each other as a society. And as part of the civil contract that we enter into as a society. In particular, we have a moral obligation to care for our seniors, and we have a moral obligation to care for people who are low income or are not of high means. And that's literally what's written into law, right? That was what it was written into law when the Medicare and Medicaid programs were established, that these are entitlement programs, meaning if you meet the eligibility criteria, you are entitled to the benefits that entails. And there's no arguing that, in my opinion. That is part of the fabric of our society. That is part of the letter of the law, that we owe it to one another to take care of people. And health is a great equalizer. Right? I told you the story of what happened to my family. That could have been any family.
Yeah.
That, right? Like diseases, life-threatening and life-limiting illnesses like cancer, or even, insert whatever illness you want, while certainly can be disproportionately, the burden and morbidity and mortality are very often disproportionately borne by people who are low income or from marginal communities. Diseases themselves often don't discriminate. And so, we have to be able to, as a society, care for people, because health, as I said, is a great equalizer. And you don't know whether it's going to be you or your neighbor or someone else. And again, I think we as a society owe it to ourselves and to one another to have some sort of safety net to make sure that when people's circumstances change, which happens all the time, that it is part of the fabric of our society to be able to catch that. And so that people don't fall through the cracks.
So let's go back to when you got out of your residency. So you said that you approached even medical school with this like eye on policy, right? So what was the first thing that you did out of school?
My first job out of I had two jobs. I've effectively had two jobs for many years now. So my non-clinical job, which is where I spent the majority of my time, was at CMS, which is the Center for Medicare and Medicaid Services, which is where I now work again for a second time. And I was a senior medical advisor in the Office of the Administrator, which is the executive office of the agency, working on value-based payment in the Medicare program, implementation of the macro legislation, which changed the way clinicians are paid through the Medicare Part B program, and clinician engagement and burden reduction work. And then my second job was at second job was clinically as a part-time hospitalist at Johns Hopkins.
Cool. So you were and both at the same time?
Yeah, I mean, I wasn't, on any given day, I wasn't like doing both jobs at the same time. But yes, I was, I did most of my clinical work on the weekends, or took leave from my role at CMS to be a full-time clinician for those days.
Yeah. I find that like the most successful people that have careers in government are the people that kind of have perspective on both sides. Like people that have either, had jobs in private industry and then gone to government and then maybe gone back and forth, or like what you're saying, where you're actually, it's a lot harder to affect policy when you don't actually know what's going on the ground. And something that I hear from doctors a lot is like, a lot of these things are enacted at the congressional level, and but they're not doctors necessarily. They don't know what's going on. Where's that disconnect? Because they're the ones that are passing the laws, but we're the ones that it affects. So I think it's incredible that you had both of those experiences at the same time. How would you say that having the real life boots on the ground experience, inside the system, how did that help inform your perspective and decision making on policy? And did anything change was there any changes in your mindset because of that?
Yeah, I mean, I feel like those two things interact on a nearly daily basis, right? I would be the first to argue that being a clinician and knowing what it means to be a clinician informs what I do in the policy space. And I would argue the converse is true too, that understanding the policy space and working in that space also makes me a better doctor. Or I think at least more effective in some instances. So, I mean, to me, tremendous value, both professionally and personally, in being able to inhabit both of those worlds. And largely, it's sort of what you alluded to, the ability to be a translator, right? So when you're sitting in policy conversations and a proposal comes up, to filter that through the lens of, well, what will this mean? Is this even possible? Who will bear the burden of this? And what will the reaction to that be? What will be the impact on timely, affordable, high quality, equitable patient care? What does this mean for burnout of clinicians? What does this mean for staffing challenges, right? All sorts of things. And then on the flip side, when I'm in a clinical setting, understanding rules around, eligibility for the Medicaid program, or understanding certain benefit packages or eligibility pathways, is useful. Understanding what people are entitled to, and therefore, what needs to be part of the conversation as we're thinking about, affordability of this prescription versus that prescription, or how many rehab days does a person have left in their benefit, and what does that mean for their recovery after a foot amputation, right? But understanding and at least having some level of fluency in the administrative side of things, I think also, is a net benefit in patient care too.
For sure. Not everyone's as lucky as you to be able to have really a foot in both sides. Is there any advice or any recommendations that you would give to someone that's a full-time clinician to at least try to have maybe some, is there somewhere to look or to read or to follow to kind of have some of that footing in the policy side?
Yeah, I think lots of opportunities, really. And I mean, it depends on the scale at which you want to engage. I mean, I would say starting the closest to the point of care, many health centers, primary care practices, hospitals, integrated health systems have a variety of committees and work groups related to these sorts of things, right? So there's, I think, opportunities at all levels to get involved. Even as a trainee, I did some of this work, to get involved in how your organization, however large or small that organization is, how your organization is thinking about and handling issues related to value-based payment, administrative burden, prior authorization, medical necessity, right? There's a lot of flavors that this takes, all the way up to, I would say more organized advocacy efforts by professional societies, like you mentioned, going to state or federal legislators to share a clinician perspective. I think there's a number of ways to do that through professional kind of aggregator organizations that bring together clinicians either by specialty or by interest and focus area. And then I'd say, reach out, conversations like this one. If there's somebody that does something that is of interest to you, I think it's always worth an initial conversation to say, hey, help me figure out how you got into this or what you do. And I think people like that, again, exist locally at the state level, federally. I'd also encourage folks to think about even outside of government too. In the private sector, we mentioned a lot about provider organizations, but payer organizations, startups, certain pharmaceutical companies, research entities, certain subsectors of academia. I think there's a lot of different ways to explore policy and administration as either, something as light touch as a side hustle to something as large a leap as actually making that full time or the bulk of how you spend your time.
Yeah. I think probably another area that you have an advantage from being in both the clinical and the policy perspectives when it comes out to clinician well-being and burnout, which is obviously a huge issue for a lot of people. What are your experiences, if any, or thoughts on provider burnout, and maybe some insight or ideas on how to deal with it?
Yeah, gosh, that's like a whole hour plus conversation, multi-day convening in and of itself. But I had the privilege of being part of the National Academies of Medicine working collaborative on clinician well-being and resilience for many years now. And I would say my overarching thought that I think is important for folks to know is there's an increasing recognition that it's a systems issue, not an individual issue, right? Support for individuals is really important. The ability for people to take leave when they need to have access to mental health resources, have access to yoga and meditation and wellness suites, all of those things are wonderful. But unless we're looking at the entire system of care and how it's structured, we're missing the real opportunity for how to address clinician well-being and stamping out burnout. The other big thought I would share is the business case for this. I think for a long time, it lived in the space of, clinicians saying, we need help, we're burnt out, we need help, we're burnt out. But having that translate to the C-suite and having it translate to executive decision makers, I think has been really important. And one of the key unlocks in that conversation was really translating for folks that burnout has tremendous, in addition to having tremendous health outcome and quality of care consequences, actually has tremendous financial implications, right? It's really, really expensive to train clinicians. It's really expensive to train and recruit and replace on a very rapid time cycle bedside nurses. It's very expensive to recruit and retain and replace as needed specialized physicians and other types of clinicians, right? And so it's making the case not just for quality of care, which is incredibly important, and continuity of care, which is incredibly important, and access to care, but the financial argument too, I think is sort of not to be overlooked.
I think that's a great, really practical piece of advice for people. Like if you feel like you are in an organization, you're suffering from burnout, or a bunch of your peers are suffering from burnout, what you're saying is don't just say feel burnt out, because that doesn't communicate well to the C-suite people. Make the business case for it. I think that's a fantastic, really just actionable item to do. And it's interesting because it actually goes really well in line with the entire shift that both Medicare and Medicaid and in general, what we're trying to push the country and the focus of this podcast into value-based care, which and taking on risk, for patients, where you're basically saying, like, let's make it so that it is more expensive for these patients to be sick than for them to be healthy, right? Like we want it to be financially better for these patients to be healthy, instead of you making money every time the patient's sick. You make money when the patients are healthy. And that kind of goes in line with this as well. Like, show the executives and the decision makers that it is actually more like, if you can put certain preventive measures into place and have check-ins with your staff and have processes for feedback, and have various steps so that you can take action to prevent burnout, you are going to make more money. So it's
potentially, yeah. And I mean, I think the other piece I would throw out there is accountability, right? That ultimately, who is accountable for clinician burnout? For a very long time, it was that individual, right? If an individual clinician is burnt out, well, that's on you. Find another job, scale back to part-time, leave the workforce, right? But I think we're increasingly seeing the trend of health systems, like large and small provider organizations, as well as payer organizations, having somebody in the C-suite whose job it is to think about these types of issues, and having shared accountability among an executive leadership team over things like well-being and burnout. I mean, tied to executive compensation. I mean, tied to performance reviews, right? That there's like real accountability for if there's a service line in your health system where the turnover is, 50% annually, what are the consequences of that to you as an individual, as a leader, right?
Right.
Not just, I've made the point about there's a financial consequence to the organization, like sort of writ large, but who bears individual accountability for that and feels responsible for changing it. And maybe it's not just one person, maybe it's just some amount of distributed accountability, but tied to an outcome for an individual.
Right. I think that makes a lot of sense as well. And, make clinician well-being a metric of both success and it goes back to your second point as well, because if it is a metric of success, then if my department or whatever I'm responsible for is failing at that, then it makes sense to connect that to my compensation, because then that now becomes part of my job, right?
Yeah, and I mean, it already has financial ramifications, right? If you're running a service line and all of your doctors turn over every 2 years, hard. It's hard to have high quality, continuous care for the people that you're taking care of, and so the turnover and the related burnout question have to be part of how you turn that department around. As an example.
Yeah, I have to say, I expected you to give a very high level, not extraordinary, because of your position. I expected it to be a not extraordinarily practical answer, but I think you just listed two really practical things that could technically be implemented tomorrow in many organizations that would have a real impact. So that's really incredible. Let's talk, let's talk about technology for a second, because when it comes, there's so many different technologies that can possibly help support clinicians. Obviously, with the advance of AI and ChatGPT and all these exciting things that are going on, which I use every single day, and it is fantastic. I have an entire dedicated screen for it. Got the Plus membership and everything. I think as someone that uses ChatGPT every day, I could very clearly say that at least in this iteration, it's definitely not going to take over any role. It's not going to replace doctors, lawyers, etc. However, the people that choose to leverage technology are going to replace the people that choose to not leverage technology, because when you leverage it, it can support your efforts, right? So that's just from my experience using it. But what are maybe some applications of some kind of cutting edge technologies? I don't know if there's AI involved or not, but what are some applications in your view of technology that can improve healthcare as a whole, or any particular part?
Yeah, so I'll try and give you some specific examples, and then I'll come back to the AI question, because I think it's top of mind for a lot of people, and I think I'll share some thoughts. I think technology has a real potential. Data sharing technology, data aggregating and sharing technology, particularly when it relates to public programs, I think has tremendous potential. As a concrete example, data sharing between health systems and vital records allows for the linking of mom or birthing parent to baby to be able to track maternal and infant health outcomes. Hugely important. Another very concrete example that comes up in the Medicaid space is for health and housing initiatives, the ability to connect Medicaid information systems with homeless and housing management information systems to allow you to understand which Medicaid enrollees or members might be experiencing homelessness and might need additional case management or outreach services, right? So the ability to get the technology that allows data systems to speak to one another. Again, as data, there's a lot of different buzzwords you can use for that, but generally speaking, sort of aggregate, integrate, and then spit out insights or be queryable for insights, I think is incredibly valuable for service delivery. I think there's the technology that exists in the palm of our hands. So things like the cameras on our smartphones being used to do a number of really wonderful things in the pandemic and before that and beyond that. So audio only telehealth, audio and video enabled telehealth, right? That allows for much broader access that is still fraught with equity issues around access to broadband. And substantial portions of this country for whom high-speed internet access is still in the pipeline and not yet a reality. But for people that do have access to it, I think creates an easier front door and a sort of lower barrier to entry for a lot of people than, can eliminate transportation barriers for accessing care. So I would highlight that as a technology, not necessarily a new innovation, but I think important and valuable in healthcare.
Right.
I think.
Sorry, I want to ask you on that, because it's absolutely correct, I think, and apparent to anyone what you're saying. The couple examples that you gave for like social determinants of health, so much of that could be addressed so much easier if there was connected data. In your view, why, at the end of the day, though, the way it is today, it is still not only are we not connecting data between the housing department and Medicaid, but it is so difficult for me to get my chart from one doctor to the other. So I've heard arguments about this, but I'm curious, in your view, what's holding up progress in that specific arena? Like, why are we still at this place where I got to be on the phone for hours and hours and call 30 times before I even get my chart transferred? Forget about what you're saying, which it's 2023, for God's sake. I mean, we should be where what you're describing.
Yeah. So what you're highlighting is what's the industry term for that is interoperability. So the ability for one electronic health record system to speak to another. And I will say, in the last few decades, we've actually made tremendous progress in that arena,
yeah.
Right? The ability for a health record management system at entity A to talk to entity B. And there are a number of different solutions to that. APIs have been helpful, application program interfaces. HIEs, or health information exchanges, that allow for, again, often statewide intersection. Some people can, not quite an interoperability issue, but all payer claims databases that will pull claims from across different payers to understand utilization trends and the like. To your question specifically about, like, why is it so hard in 2023 to port your record over from, like Dr. X to Dr. Y's office? A lot of different, there's a lot of interpretation along the way around how to handle privacy, how to handle consent. So there are very real issues wrapped up in why it is intentionally, why people want to be intentional about the moving of health data, right, in a way that is compliant with federal law and does not unduly disclose health protected information. So that's part of it. I think part of it is also the way these systems were designed and what different EHRs needed to be certified. And that certification initially didn't have interoperability front and center, although now it does. And so there are efforts at the federal level from a policy perspective to make sure that any EHR that is certified in this country meets certain standards for interoperability. I will say, I think the slow uptake of that is less about federal policy and regulation and more about the actual implementation of, like, the implementation within a given EHR to another, and the general reliance of healthcare on very antiquated technology like fax machines.
That's so true. Yeah, I mean, the argument that I heard that I'd be curious to hear your opinion on this, but it resonates with me. I mean, I agree with it. The argument that I heard is that, like you said, it's not a policy thing. It's basically the people that, right now, there's basically a monopoly on data because the people that own these EHRs or those companies essentially own that data, and they don't want it going everywhere. They don't want it being easily accessible. And the interesting, so I'm not saying I agree with that because I have no idea. That's either fact or not fact. That's not an opinion for me to have. Where I do think is interesting is that I think there's a generational shift when it comes to the sensitivity. And this, to me, as a young person, is absolutely apparent. There's a generational shift when it comes to the sensitivity surrounding, PHI and personal health information. Whereas even like my parents, I mean, for putting a credit card into the online, you know what I mean, is like the craziest thing. 10 years ago, and even to that generation today. I think since we live in such a connected world, and obviously the rise of just technology and social media, and the fact that everyone's info is everywhere, I think that sensitivity has gotten a lot weaker. As like I don't think people in their 20s care nearly as much. Like they would rather the convenience of being able to quickly access things and send things this and the other, rather than everything being locked up. Do you see that generational shift? Would you agree with that or no?
It's an interesting point. I do. So here's what I would agree with, which is I think maybe a variation on what you're saying. I think the average consumer today is used to a more seamless experience in other sectors than they get in healthcare. Think about how easy it is for you to order groceries online. Think about how easy it is for you to do, like, when was the last time you set foot in a bank, right? Like, think about how easy it is for you to handle your personal finances, for you to handle basic things like obtaining food. Online in a way that also deals with sensitive information like your bank account number or your credit card information, right? You can apply for a mortgage in 5 minutes on your cell phone, right? And so I think it is absolutely the case that consumers, regardless of age, just like take the average consumer, age agnostic, today versus 10 years ago, is certainly more accustomed to those experiences of like a slick user interface that allows them to quickly and conveniently accomplish whatever task it is they're trying to accomplish.
Right.
And I think that demand pressure, like consumer demand pressure, has absolutely already infiltrated healthcare, right? Like I think like you see many startups across the healthcare value chain that are sort of designing with that in mind, with like convenience, accessibility, portability, mobile enabled. So whether I would call that a generational shift or not, I think hard to tell. And I don't have any like data or information to support XYZ age group versus another, except that, like the change in trend over time.
Right. Yeah. Well, I know we're coming up on time, and I think we could probably talk for hours, and it's an honor, and I appreciate you taking the time. You're sitting in a very impactful position, obviously. And as at the end of your career, you look back, what is something that you would have wished to accomplish through your role as Chief Medical Officer at Medicaid that maybe is not there yet, but you would like for that to be when you're done?
Yeah, I mean, I think for me, the more people that can have access to healthcare services and supports, and the more that access is equitably distributed across the population, the better, right? And that to me is enough to fill a lifetime and then some, whether it's in this job or in any other. But the North Star for me is always people deserve access to healthcare coverage, and they deserve access to the services that healthcare coverage enables them to have to live healthy, productive lives. And it's not fair. It's just flat out not fair that that's available to some people and not others, by virtue of what I would argue largely random chance and historical systems that perpetuate inequities, right? And so whatever I can do to make it a little more fair and a little more accessible and a little bit better is worth it.
Fantastic. And I think it's incredible that you tie the end with the beginning, and again, contrasting where the origin story of your interest and firsthand experience of lacking that access to healthcare, and that basically just driving your mission, I think is fantastic. I commend you for your obvious passion and drive. And I'm sure it's exciting to see what you'll continue to accomplish. And thank you so much for joining today. It's fantastic.
Thank you for having me. It's still the very